So here we'll go through a primer on spinal canal and neuroanatomy. This will be a pretty quick session. We're going to go through the spine, spinal nerves, and then the muscle stretch reflex. So the spine itself, the anatomy, there is a vertebral body which is anterior, arch which is posterior, and the arch has pedicles, laminae, and processes. When we look at the setup of the spinal canal here in sagittal view, we have 33 vertebrae. And the key thing to differentiate is that there are 7 cervical vertebrae, but then there'll be 8 cervical spinal nerves. There's 12 thoracic, 5 lumbar, and then there's sacral and coccygeal as well. So when it comes to the spinal nerves, again, 8 cervical. So what does that do? Well, the cervical roots exit above their corresponding vertebra. The thoracic roots and below exit below it. Why is this? If there's 7 cervical vertebrae and 8 cervical spinal nerves, then C7, when you get down to C7, the lowermost cervical vertebra, the spinal nerve goes above it. So where's C8 going to go? It has to go below C7. So then where is T1 going to go? It has to go below T1, and so then the pattern continues inferiorly from there. This is the arch of the spine here, of the vertebra, and this is, you can see these various processes. They're important to know: cold, spinous process, transverse process, the laminae in between them, and then the vertebral foramen right here, and then the various pedicles. Again, this is some core anatomy here. In terms of the body, just think about the compact bone peripherally, and spongy bone centrally. This is a lateral view. Again, here we have the body anteriorly, and then we have the arch posteriorly here, various processes. We can see the spinal nerve emanating here from the intervertebral foramen right here. And then in between these bony structures here, the vertebral bodies themselves are intervertebral discs. And so one of the most common causes of musculoskeletal pain is tearing, annulus fibrosis tearing, and then this spongy disc material can put pressure on, compress nervous system structures and various musculoskeletal structures in the spine. This is just an important physiology notation. This orientation of the facet here, this BUM, BUM acronym is helpful: backward, upward, and medial sometimes for the superior articular facet. That's just one of those pearls. Spinal nerves themselves. So the roots, we've talked about this quite a bit: dorsal, posterior, sensory; ventral, anterior, motor. And then there's a differentiation between rami and roots, which we'll talk about when we lay everything out. But essentially there's a dorsal ramus which innervates the back, and then there's that ventral anterior ramus which innervates the limbs and anterior torso. Here again is our arch, here's our body, and then here's our spinal cord itself with the dorsal horn, sensory, ventral horn, motor, and then intermediate zone, autonomic. So the dorsal root, remember the dorsal root has a dorsal root ganglion. This is a pseudo-unipolar nerve setup where the sensory cell body lies peripherally in the dorsal root ganglion. Here's the innervation here through the dorsal root, and then for the motor system, the anterior horn cell just emanates out its fibers through the ventral root, and then they meet up to form this mixed spinal nerve. From the mixed spinal nerve, then we get into the rami. So here's the anterior ramus here. It's innervating its, remember, limbs and anterior torso. And then there's a dorsal ramus here, a posterior ramus, which innervates the back. And we just have our little quick call out that rami are not roots. Now we layer in the sympathetic nervous system fibers here. So out of the intermediate zone we go. Now, differentiating between the gray ramus, which is unmyelinated, and the white ramus, which is myelinated. It's a key anatomical pearl. So innervation comes in via the white ramus here. It innervates along, in this example, the sympathetic chain. And then from there, there's a post-ganglionic sympathetic fiber that innervates, for instance, in this example, the heart. Facet block is a clinical intervention. You disrupt the posterior ramus to treat painful facet joints. You can use denervation, anesthesia, and then even electrical stimulation. Muscle stretch reflex. We're going to walk through all of the steps of the muscle stretch reflex because it's so core to clinical medicine. So what is the stretch reflex? It's an automatic monosynaptic reflex that involves a muscle, tendon, and produces a jerk response. So there isn't a lot of layering to the innervation, and that becomes really critical in physical examination. Here's our key mediators that we're going to account for in the reflex. So here's our setup. We're doing a patellar reflex, which is L2 through L4 in our example. What do we need? We need a leg. We need extensor muscles and flexor muscles. Extensor muscles of the thigh, the quadriceps, that's what's going to cause the leg to extend. So the first bit of anatomy that we need is a type 1A sensory nerve. This is a large fiber sensory nerve, heavily myelinated, 120 meters per second. So there's going to be a volley of information that's then going to be passed along. Now remember, it's monosynaptic, meaning it only forms a single synapsis, so it's going to pass all the way directly to the anterior horn cell, the motor cell. And then there's also, we see this break-off, which is the Renshaw cell. This is an interneuron, and we're going to see that we have to activate the extensor, but then we also have to inhibit the flexor, otherwise the leg would just stiffen. So here's our reflex hammer. We tap the patella, we stretch the muscle spindle here, volley of information comes in, activates both of these, the Renshaw cell and the anterior horn cell, the extensor, and so then we inhibit the flexor motor neuron, and we can see that it passes through a type A alpha motor nerve, again, large, heavily myelinated fiber. It inhibits the flexor, and then the extensor motor neuron activates the extensor, and then we see the leg extend at the knee. So that's activation. Now we also have to have termination. So we have our same setup as we did for activation here. The leg is extended. We introduce our Golgi tendon organ, and we maintain our type 1A sensory nerve coming off of the muscle spindle, the extensor muscle. Now we introduce this type 1B sensory nerve, again heavily myelinated, it's type 1, and now it's activating this Renshaw cell here, only this Renshaw cell is inhibiting the extensor muscle. So then there's inhibition of the extensor muscle and thus termination of thigh extension, and the leg relaxes. So here's just a quick bit of information. Muscle spindle, passive muscle stretch, the Golgi tendon organ, active muscle contraction. Key reflexes, again to know cold, biceps C5, C6, triceps C7, C8, patella L2 to L4, and Achilles S1, S2. That's a quick whirlwind through the spinal canal, but some really core gross anatomical information of the vertebral column in there, and then some key clinical information when it comes to evaluation of neuromuscle integrity.